Morena koutou. Thank you to Mark and the organisers for inviting me today. I am at Burnett Foundation, Aotearoa. I've been in this role for about 18 months now, and my team plays a role in advocating for structural, legislative, regulatory policy change to support people living with HIV, but also our rainbow communities. We do a lot of workforce development and making sure everything is informed by evidence and community. So I think Mark invited me to speak today because he wanted someone else to be a bit provocative. So yes, thank you, Mark. So I'm sure most of you are aware of this. PrEP is pre-exposure prophylaxis, antiretroviral medicines to prevent someone from acquiring HIV. It's very effective, and globally we're entering what is being called the era of PrEP choice. So you've got the tablets, which are up on the screen. You can take them daily, or you can take them around periods of risk. There's also the dapivirine ring, which is a silicone ring that can be inserted inside the vagina, and it slowly releases antiretroviral drugs over the course of a month. And we also now have long-acting injectables. So we've got cabotegravir and lenacapavir, two different formulations. With the lenacapavir, you only need to have a subcutaneous injection every 6 months. So real potential for being a game changer in the prevention space, would reduce the amount of clinical visits required, and a much more acceptable and discreet option for many people, which is amazing. I was a bit ambitious in what I thought I could include in this presentation, so I'm going to whiz through a little bit, bear with. I just want to go over the current state of play in New Zealand. So what are some of the current processes for accessing PrEP, current pathways, before looking at what's working well and what we could do a bit better. So whether we're in an era of PrEP choice in New Zealand, you get to choose between daily and 211, because we only have the tablet formulation of PrEP. We're advocating really hard to get access to long-acting injectables, but at the moment there's no sight of them. We'll keep trying though. In terms of accessing PrEP, the eligibility criteria has evolved quite a lot over time to be much more expansive. And so when we initially got PrEP in 2018, it had to be initiated by an HIV specialist, and the special authority criteria was quite restricted. So people had to test negative for HIV, but also report multiple episodes of risk in the preceding 3 months, and STI diagnoses. So someone had to put themselves at risk of acquiring HIV in order to access the prevention tool, which is a bit nonsensical when you think about it. In 2020, changes were made to allow PrEP to be initiated in general practice, which was amazing. And in 2022, the special authority requirements were also lessened to allow for clinical discretion of PrEP. So rather than talking about eligibility criteria, we now talk about suitability. So someone just has to test negative, and the clinician or the prescriber has to consider them to be at an elevated risk of HIV, and that PrEP's clinically appropriate. So yeah, nowadays PrEP can be initiated by GPs, sexual health clinicians, by nurses, nurse practitioners, and any relevant prescriber, which the definition from Pharmax there. And in 2023, the New Zealand Sexual Health Society partnered with Burnett to release the clinical guidelines for PrEP and PEP, and this covers everything you need to know, from safety and efficacy, indications, monitoring. At the moment, someone on PrEP has to have HIV and STI tests every 3 months, renal and urine PCR tests every 6 months, and Hep C at least every 12 months, although more in some populations. In terms of how we're doing, globally PrEP uptake is stalling a little bit. So we've had the oral formulation of PrEP for 12 years globally, and during that time 6.7 million people have initiated PrEP, but during the same time 17 million people have acquired HIV. In New Zealand, in 2022, we think that there were just over 4,000 people accessing PrEP. This was from some analysis that Hayley Dennison at Massey University did, looking at pharmaceutical dispensings in the IDI. However, we think that there are about 10,000 MSM and their sexual partners in need who, report behaviours that would put them at elevated risk of HIV. So, there's a range of reasons why this uptake is low. The SPOTS study and the thesis of Cam Leakey looked at a PrEP cascade to look at, the range of things. We've got the PrEP suitable population, so this is the population of people from the SPOT study who reported behaviours that would they would be considered at elevated risk and therefore suitable for PrEP. So of those people, how many were aware of PrEP, how many were willing to use it, and how many were on PrEP? And you can see that there was high awareness of PrEP and good willingness to use, but the drop-off comes at use, which suggests that there are issues in terms of access at the access level. And if we break it down by ethnicity, you can see in the grey and orange that this is particularly lower for Māori and Pacific populations. And I think also in terms of equity, important to note, not everyone has access to publicly funded healthcare. So when you think of temporary migrants, they have to pay for not only the cost of the appointment, but also the tests required and the medication cost. And we did a bit of a calculation as to what that would amount to every 3 months. And it ranges from 217 to 558, depending on whether you go to the lab or do some self-swabs. So obviously that's not going to be affordable for many people. And there are a range of enablers and barriers that could be affecting PrEP uptake. We ran a little community survey online just through our social media channels just to see what people's experiences were like accessing PrEP. Just over 300 people replied to the survey, and we did a little thematic analysis. So you can see on the left are enablers and on the right are some barriers that were reported. In blue, you can see that the role of the healthcare professional played a really big part of the experience. So respondents who reported that their prescriber was knowledgeable about PrEP and non-judgmental, that was a real enabler and made things easier for them. So in blue, doctor has been very easy to deal with no issue getting prescription, no judgment or difficult questions. Conversely, on the other hand, some people felt that their health professionals didn't have appropriate training, or that they felt judged by their healthcare provider. So lack of knowledge and education GPs have about prescribing PrEP. I'm anxious that the attitude of my doctor would not be positive. In terms of another enabler in green, you can see that there were quite a few respondents who reported accessing PrEP via telehealth, and they felt that this was a really enabling factor. It made it really easy and convenient for them to access PrEP. So online doctor to avoid awkwardness and judgment from in-person GP, phone appointments for sexual health, test sent to lab tests to just walk in and complete. So really easy. In yellow, we've got some things around access issues. So the ability to access PrEP via general practice was reported as an enabling factor for many people. It was really simple. I just went to my GP. My normal GP now prescribes. On the other hand, a lot of people reporting issues around wait times for appointments, and inaccessibility of providers due to their location or their opening hours. I think particularly with GPs, it's a big issue we see. So inability to get access to PrEP as it's too far, and the sexual health clinic is always closed on weekends when I go. Access to healthcare appointments are weeks away. And then unsurprisingly, in purple, we've got the ongoing cost of being on PrEP was considered a challenge. So, even having to pay to go to your GP every 3 months to get your next prescription. So yeah, there are a number of things that we are doing well, and there are some amazing clinics and doctors and nurses out there who are doing amazing mahi in this space. And, this is some of the things that we talk through in our workforce development sessions about ways that clinics can make sure that they're, open and welcoming space. Maintaining privacy is a really big one, so not assuming a person has disclosed their sexual activity to others. I would also argue that there's an increased role that nurses can play, and nurses can do a lot. So in your clinic, thinking about what task shifting can occur, how can we delegate tasks from busy healthcare workers and specialists to a nurse? How can we enable nurses to do the screening and education, but also do some of those assessments? Yeah. And then really important to also think about the design of services and the user experience. So the British Association for Sexual Health and HIV, they recently released some draft updated guidelines. And I thought it was really interesting in the clinical guidelines because they've got some questions. And they suggest anyone who offers information or support to potential PrEP users or designs or delivered services should consider who attends the clinic and who does not. What is the physical and social environment when they arrive at your clinic or service? What demands are asked of them within the clinic or service? So the demands could be resources and that, you're charging them for the clinic. It could be knowledge and that, you're requiring them to know about you or know what behaviours they need to tell you they've been doing in order to get access to PrEP. And then also in terms of knowledge as well, in terms of behaviour as well. Also important to think what support do they need in understanding and using PrEP within their sexual and social lives, and how might the physical and social settings in which they live affect their PrEP access and use. So these are questions that everyone providing PrEP should be thinking through. I think quite often PrEP is initiated by the client, so a client will come in and ask for PrEP, but there's a lot more opportunity for a PrEP to be provided and that conversation to be initiated by the healthcare worker, and it's quite a different conversation. I have a video of some GPs and nurses who describe this really well. I'm hoping that it goes.
I think that's a really good question, is like, how do we address the PrEP for the person in front of us? But I think what we have to do is make sure we're prepared, that we're aware of our biases, of our information as clinicians before we actually make that step. We need to make sure that we are indicating to a person that we're an okay person to have that conversation with. I haven't got my lanyard on, but it's rainbow, trans-inclusive colours, so that there's green flags, green flags all over the place that indicate you might be a safe person to talk to. I think we should just say that there are things available for people who are at higher risk of acquiring infections like HIV. This may be relevant to you or for you. And just start the conversation.
I personally can't underestimate how empowering it is for the clinician to bring it up once you have identified the person as at risk. I have had so many people where I've brought it up and they've gone, oh, thank goodness, I've been thinking about it, but I just haven't really had a conversation about it with anyone other than my friends. Yeah, so the first thing I usually say is just, have you heard of PrEP? Or have any of your friends been on PrEP? And so you're sort of framing this, the question, and you're not just directly asking them about their sexual characteristics and what they get up to. You're just asking them, have you heard about this medicine? And that's a good non-invasive way of just screening for their understanding, where they're at in terms of their own thoughts with it, and how much, I guess, groundwork you have to do to sort of push the idea of PrEP.
For repeat PrEP scripts, to try and make it as easy as possible, so yeah, we get people to come in for their appointment, they do their bloods and swabs on the day, they leave with the script, and we text them the next day or within 2 days with their results. So initially we were seeing people every 3 months. As we get more comfortable with PrEP, the next logical step from seeing people every 3 months is to see them every 6 months. And what I do there is they see me for their scripts, bloods, swabs, urine in the consult. Then I set up the next lab form for their next script for 3 months' time. So then they just turn up at the lab and the form is there, or they've got a copy of the form. And then once they've done their bloods and swabs and urine, they request a repeat script through our nurses or through the patient portal. And then the time after that, they come in and we repeat the process again. So that's a really easy way to stretch out from 3 to 6 monthly. We do have a policy where we try to see people at least every 12 months, and I think it's sensible to check blood pressures at least once a year with PrEP. One of the other time-saving tips in terms of operations is that if I am running 20, 30, 45 minutes late, I will just get the nurses to do the throat swab and label all the swabs and urine, and so just had to let them know how to do it, but now our nurses are super comfortable with doing all of the PrEP swabs and blood and swabs and urine, as well as doing the blood test for them.
What does affirming holistic care look like for a human? So it's like, what's that person's needs, and what can we do to actually help that person make decisions and have actions? Is there any way we can augment that with medication that's going to be helpful for that person? I think for me, having a belief around people's rights to make decisions for themselves is really important, because then you're just supporting and affirming then working in partnership with a person, like not the finger wagging what you should or shouldn't do, is really important, because you cannot finger wag someone into affirming care. And like, I'm sex positive, you know, what a person is doing for themselves to ensure that they feel sexually satisfied and complete is actually up to them.
Sorry, Suzanne. I think that's just a short clip from a longer video, and if you want to watch the full thing, I can send you the link. But it's just some ideas about ways that we could be doing things better, or, you know, operationally how we can simplify things a little bit just to make the whole process a bit easier. But I also wanted to talk about how we can make the whole pathway and experience to accessing PrEP much easier. And one way we can do that is through differentiated service delivery. So this is a client-centred approach that simplifies and adapts HIV services across the cascade of care to reflect the preferences, expectations and needs of people living with HIV and our key populations in need of a service while reducing any unnecessary burdens on the health system. So the WHO have been recommending differentiated service delivery for across the HIV cascade of care since 2015, and it can and should be applied for PrEP assessments, initiation, early follow-up and continuation, and it's part of this broader global push for thinking about how services can be demedicalised, simplified, differentiated, digitalised and integrated into broader healthcare in order to increase uptake and make sure that we're reaching as many people as possible. And so the building blocks of differentiated service delivery are these ones here. And these are things that you need to think through when you're providing a service. So how often do you have to see the person? Is it every month? Is it every 3 months? Could it be every 6 months? Torrance provided an example of how he tries to reduce the face-to-face interactions to every 6 months. So we need to think about what we can do to reduce barriers and make it easier for people and reduce the number of interactions where someone has to go out of their daily routine to access something. We could also think about where a service takes place. So does it take place in a clinic or a pharmacy? What could they do from home? Are there self-tests or self-swabbings they could do? Is there a mobile clinic that we could set up? In terms of the who is providing the service? Is it a clinician? Is it a GP? Is it a nurse? Could it be a pharmacist? Could it be a peer? And then the what, so what's included in the service. And that's looking at, initiation and refill, but also monitoring and adherence support and testing. So I wanted to go through a few examples of ways that we could think about differentiated service delivery in New Zealand. And in terms of the who, I think, we know that access to primary care is difficult at the moment in sexual health clinics too. Under capacity, overburdened, and sometimes long waiting times for appointments. So internationally, there's growing interest in the role that pharmacists can play. Pharmacies obviously provide services for extended hours, sometimes 24 hours a day, and patients can receive care without having to book an appointment. So much more accessible option than primary care for many individuals. I think pharmacists also have a lot of experience providing referrals and that linkage into mainstream care, and they're a much more acceptable option for some people who don't want to go into a health clinic. So could be a significant additional access point for us. Internationally, there's lots of different countries who are passing legislation to implement pharmacist provision of PrEP, and a lot of countries who are conducting research to explore its impact on increasing uptake. So the US is doing a lot of work in this space. I think 14 states have passed legislation to allow pharmacist provision of PrEP. And, they're all a little bit different in terms of how they're doing it. In California, pharmacists can supply up to 90 days of PrEP, and they can prescribe beyond 90 days with testing. And they can do all parts of the consultation and testing within the pharmacy. However, in places like Seattle, there are difficulties similar to here in terms of who can order tests, and so there's a lot of initiatives where it's a pharmacist working with an HIV specialist or clinician who has oversight over the testing side of things, but the pharmacist can perform a lot of the specific functions, including initiating, having that conversation, and doing the monitoring of PrEP. So, some interesting stuff happening. This is something that we could do now, either by a national standing order or standing orders in different regions led by different health clinics. It would just require a partnership between some clinics and pharmacies. The clinician would have oversight over the testing and do the ordering of testing, but the pharmacist would have those conversations. And it's one less visit that someone would have to do. So something that we're really interested in looking at and really excited to do. We're hoping to set up a pilot for this soon. Last month or month before, we also submitted an application to the Medicines Classification Committee to get PrEP reclassified so that a pharmacist can supply it. And that'll be considered by the committee early next year, and if there's any clinicians in the audience who'd like to provide a letter of support, we'd really appreciate that. Basically, like someone would go into a pharmacy and have that consultation. There would be a checklist, which is the criteria under which the pharmacist could supply PrEP. If there's anything that's a bit more difficult or complex, of course, you'd do the referral to a clinician or someone with a bit more expertise, but you know, a clinician or Burnett Foundation can help to support the testing process, and the person's only required to go to the pharmacy and maybe get a couple of other tests. So could be something, you know, really significant. We should also think about what role community can play. So globally in the HIV response, there's a lot of calls to better integrate community voices into decision-making processes, and to ensure person-centred, culturally tailored care. I guess communities are experts, and we know what each other needs, and we know you know, where people are going to feel comfortable. A lot of people are going to feel much more comfortable having those conversations with a peer rather than, you know, a doctor. So thinking about ways that we could enable that. There's lots of interesting examples globally of places doing this. The most well-known one is probably the Princess PrEP project and the Tangerine Clinic in Thailand. So they trained community health workers who were also members of the key populations they serve to provide PrEP. And at one point, 85% of the country's PrEP users obtained PrEP through their community clinic, which is pretty amazing. In the Philippines, there's a similar example where people are accessing PrEP via their community clinic, and that's done through a partnership with a clinician as well. A lot of the time, some of the barriers to community provision of PrEP is around who can order tests and who can hold medication stock. But I think it's really important that we think of ways that we could enable that, maybe via a hybrid model where a peer and a clinician could work together, or a peer and a pharmacist could work together, so that all of those conversations can happen in community where someone might feel more comfortable, but you know, a clinician would still have oversight over the testing things, and if something does pop up, we can provide that warm handover. But it could be yeah, it could be really helpful for some people to access PrEP. And then in terms of the where, we need to have services where the people are, and make things as convenient as possible. So there are a lot of interesting initiatives where people are providing PrEP online through telehealth appointments. So you can have like an online consultation, which is much more convenient for a lot of people, of course. There are some initiatives where the person's only required to fill in a form, so they don't even have to have that consultation with someone. They just fill in the form, go for their tests, and then you know, a clinician looks at the test results, and then they get provided the script. So that's what's happening with the 5016 Street PrEP box example. And a lot of these initiatives, like the Mr. initiative, they're doing all self-testing and self-swabbing, so someone doesn't even need to go into a lab. I'm not sure what they're doing for kidney function, but they said all tests are done at home, so yeah. And then there's also some cool initiatives where people are partnering with sex on-site venues, so 5016 Street and PrEP Box partnered with a sex on-site venue where they not only got people on PrEP but did mpox vaccines and testing as well. So how can we better integrate services? In terms of the what, this is probably the most controversial bit, was recently over in Munich at the International AIDS Conference, and there was a panel there called Does HIV Monitoring Need to Be So Complicated? And the expert panel there said no. Very aware how many clinicians are in the room. And they said only test is required is an HIV test. I think, you know, what's most important is that we're preventing people from acquiring HIV, and we can't put barriers in the way in order to achieve that. So, of course, there are going to be some people who need wraparound services and ongoing monitoring, but we can't let perfect be the enemy of good. And those who can manage PrEP themselves should be able to to free up the health systems for people who need more intensive services. The WHO is also calling for an expanded role of HIV self-testing. So how can we incorporate self-tests into the initiation and monitoring of PrEP? And then, does everyone need an EGFR? I think, particularly for younger populations, is something to think about, just because, the renal function issues are incredibly rare with younger populations. And yeah, I think STI testing is a big one for me. It's really important that people are getting regular screening for STIs. We've got, a big syphilis epidemic, and so it's really important. But does that need to be bundled with PrEP? Can we encourage people to have regular screening without holding PrEP, away from them? It shouldn't be that you have to do the STI testing to get access to the tool that's going to prevent someone from acquiring HIV. And then in terms of the when, so these were some of the things that we brought up earlier and that Torrance was raising. I think we know quarterly testing can be both a financial and time burden on people, but also on the health sector. So all of the examples I've talked about in differentiated care have been 3-monthly testing, but it's probably worth us having a conversation around what are the benefits of 3-monthly testing versus 6-monthly testing, particularly for STIs, and how can we make the whole process a bit easier? What role can self-tests play? One of the concerns that always comes up, of course, is what about resistance? So because the key drugs in PrEP are also frequently used as first-line treatment, if someone does acquire HIV, there's concern about the drug resistance that might occur from not treating the HIV well enough. And there are a couple of mutations that are strongly associated with PrEP. My question for clinicians would be, how much patient education are we doing in terms of adherence support? If there is resistance, is that clinically significant? Can you still have a suppressed viral load? The benefits of preventing HIV with PrEP far outweigh the risks of some of the things that people are worried about. So moving forward, as Sue mentioned, 2030 is our big target for eliminating new local transmissions of HIV. We've actually got just 5 and a bit years now. We really need to ensure that equity is front of mind and that we're addressing all factors affecting access and uptake to PrEP. Our GPs and sexual health clinics are really overworked and overburdened, and we need to increase access to both PrEP and PEP beyond sexual health. So for community settings, online services, drug and alcohol services, community pharmacies. While a lot of this presentation has talked about PrEP, I would argue a lot of it can be applied to PEP also. I think PEP is really underutilised in overly medical intervention, and we need to have that conversation. And yeah, let communities lead. We can, we really need to do all we can to reach the 2030 targets. So thank you to these amazing people for their data and research skills, and thank you.
That was awesome. Thanks, Brooke. And it wasn't controversial at all. It's all the things we need to do. We do have a few minutes for questions if people have something.
Hi, I am a GP who prescribes PrEP. We work in the central city of Auckland, and I see a problem with pharmacists doing it, but I'd be open to hear the solutions, in that they don't have a separate room to have those conversations. That's the one thing. And the pharmacies I always go to, you're talking loudly across the counter to the pharmacist. And the other one is we see our patients as often as we can, and we pick up incidental infections a lot, and then we can treat them on the spot. And it's an efficient way if GPs can do that, I think. I'm not sure how pharmacists would go with that.
Yeah. It's quite loud. I would say that, pharmacists, some of them do have consultation spaces out the back, but a lot of them are used to having these kind of more sensitive private conversations because of the morning after pill or around Viagra. And so they do know how to manage these conversations a lot of the time. What was the other question?
Opportunistic testing for other things.
Yeah. Yeah, I mean, seeing people every 3 months is the thing. Like, it is a big cost having to pay to go to your GP every 3 months and get all of these tests on people who are managing PrEP well. And it's probably important to think, like, it would be good to have these opportunistic interactions, but do they need to happen every 3 months? If you see someone every 6 months, can you have a more comprehensive consultation then, or can you space them out over the year? Yeah.
The other thing to think about is just initiation versus refill, I think, is the big thing for people. And a lot of people have been on PrEP for like 6-7 years, and they have to go in every 3 months, and every time they go in, they're asking about their meth use and all these other things. And it's like, well, this is my prevention tool. Why is it so hard for me to access this tool? So I think that's, for a lot of people, it's like, how do we make it super easy for them to access it, and then educate them about how to be adherent to it? Because one of the things with testing for HIV every 3 months, people say to me, it's like, well, is that because PrEP doesn't work? Is that why you're testing me for HIV? It kind of reinforces that kind of misconception around it. And I think that education piece is really helpful for them to understand why it's important to get tested for STIs all the time and to be enabled to access this tool. So, yeah.
Yeah.
Sorry.
Hi, this is Josh from Asham. I was just wondering if there was any thoughts on like how like whakama or shame needs to be addressed in some of this as well.
Yeah. I mean, definitely, and I think a lot of the times that's where peers and community can play an important role, or even, online services, so you don't actually have to have that conversation with someone. You can fill in a form, so there's a lot more opportunity to address issues related to shame when you take the person out of it and having to have that interaction. Yeah.
Kia ora, Brooke. Thank you. Just a quick response to the GP and yourself, I guess. You must be aware, Mark, and I have had a small project going at a community pharmacy, understanding orders. I just have been sloppy in presenting the results. However, it's a very successful, I believe, pilot with access to PrEP. So the model is there, it works. There are some issues, and from the GP perspective, the follow-up of positive STI in terms of consuming their resources is one of the glitches. The 3 months prescribing, if it moved to 6 months, that would be great. I'd caution against reclassification or put some caveats in there, because that will shift the costs. So yeah, just so we do have some experience, and it's been a good one. Yeah.
With our reclassification application, it's quite similar to the standing order, in that there's a checklist that, if the patient would meet these criteria, this is the conditions in which the pharmacist can supply it, and anything beyond that, they would be referred to a specialist or a doctor. So there's still the pathway for that. Yeah.
Hi, Brooke. Thanks for your presentation. I'm one of the nurses at Auckland Sexual Health, and I was just wondering, because nurses do quite a bit in this space, if you'd looked at the adding it to the RN designated prescribing.
Yeah.
Because at the moment it's not one of the drugs that's listed.
Yeah, that is on our list to do. We were hoping to do it with the current update, but I think the timing didn't quite work out because they need to go out for consultation. But it's something that we're really keen to do, because that would widen the range of nurses that can do it. So yeah, that would also be amazing. It's on our list.
Kia ora, I'm Suzanne, who I'm very sex positive. I work with Renee, and at Auckland Sexual Health, the nursing team does a lion's share of the work. And with a reclassification, if it does get through with pharmacy, it would actually mean that nurses that are community nurse prescribers and designated nurse prescribers with education training could actually do that work and do the prescriptions, which would open it up a lot to other youth health services and sexual health services. But we see our clients once a year. Everything else is done over the phone unless they particularly want to come in. And it's the nursing team that really leads that, does the histories, works out what they need, arranges treatment and follow-up. If they've got chlamydia, they prescribe that over the phone if they're designated nurse prescribers. So it's kind of like, how can you cut your cloth with what you've currently got? And I just think they do an amazing job there. But, you know, limited resources, but work out how you can kind of make your resources stretch as much as you can.
Yeah, it's a really good point, and it's amazing how you can only require them to come in every 3 months. Just yesterday I got an email from some of our support staff down in Wellington who are asking for support because they're finding that there's a blanket rule among many GPs in Wellington that GPs must see their client in person every 3 months. So, yeah, unfortunately there's still some places that need some support.
Just a comment, Holly, about the pharmacy. When we're trying to integrate sexual transmitted infections screening in cats, one of the comments that I got from many of the counsellors and clinicians who were, like, my idea was to have them available in the toilets, but they felt that was culturally not acceptable. Not even to be offered for one of the settings, for clinicians from Maria Pacifica, especially the Pacifica community. But what they did say is, if this were available in the pharmacy, STI testing available in the pharmacy, not having to have the conversation with anybody, they will do it. So I think if we move like we did with COVID, we move where they are, people will engage. But at the moment, for example, we ran the first clinic on Tuesday, and we were in the groups, but just getting people from there to the clinic is so difficult, even in an open, friendly environment like Cat sees. So I really strongly encourage you to, you guys have supported me with Cats, but to talk to all the NGOs who are working in the addiction space, because the lack of awareness about this relationship is massive. Like, we did a survey, and the majority of people were not aware of sexual services, or the Burnett Foundation, on Body Positive. So we do need to work together.
We've got one more, then we have morning tea because we're running late.
Yeah, just a comment about the monitoring. I certainly think that could be simplified, and there was a lot of discussion at the ILST conference and about the need for regular STI testing, which I think is not actually that relevant to providing PrEP safely. I certainly wouldn't advocate for dropping the 3-monthly HIV testing, just in terms of monitoring, being able to capture people early when if they've been unlucky enough to acquire HIV. And I certainly think syphilis is important because it's a serious STI with serious complications. But in terms of the multi-site STI testing, I don't think we need to be doing that as regularly as we're doing. We could drop that easily to 6-monthly, or if people request it, certainly I think they should be allowed to have it, but I don't think we need to do it 3-monthly. There's a lot of discussion about these infections are asymptomatic. They don't usually cause serious sequelae, particularly in gay and bisexual men. So that would be one way of, simplifying the monitoring and the cost.
Yeah, awesome.
Okay. Thank you, Brooke. That was great.